So is it really justified to transplant these patients after downstaging portal vein tumor thrombosis? So let's first understand what we're talking about. VP0 is no tumor thrombus. VP1 is anything distal to the second order. VP2 is in the second order branch. VP3 is left and right portal vein. And VP4 is main portal vein or even further up into the SMV. So traditionally, these kind of patients who have portal vein tumor thrombosis will be relegated to palliative care, even now in 95% of the centers, with which they will get 3 to 6 months survival. And with the latest tyrosine kinase inhibitors and immunotherapy protocols, they might get up to a year and a half, 19 months. But the American and the European guidelines still contraindicate resection for such patients. They absolutely contraindicate transplantation. And let's see if this dogma needs a change. So my argument basically rests on 4 pillars. The first is, most people consider PVTT to be systemic spread. I debate that. I don't think that PVTT is systemic spread. It should be considered to be loco-regional disease unless proven otherwise. The second is, that has been shown over the last 10, 15 years, that tumor in the portal vein tumor thrombus, the tumor part, can actually regress partially or completely with radiotherapy. The third is that we and others have shown long-term survival after radiotherapy based downstaging protocols followed by liver transplantation. And the fourth is, whatever survivals you get are far better than the alternative. So there is a clear transplant benefit. And these are the reasons why I think that selected patients of this kind can have a transplant. Now let's look at the actual evidence. What's the evidence that PVTT is not necessarily systemic spread? There were early papers nearly a decade ago from Korea, 2 of them. So these people had like 11 patients who they did not downstage. These had HCC PVTT, and they were able to achieve a 5-year survival of 63%. And they felt that if the patient had a low AFP and only had VP1 through 3 and had a small maximum tumor size and did not have FDG positivity, then they would be candidates for this kind of protocol. But of course, one should downstage prior. So this is another paper, also from Korea, 27 patients with VP1, VP2, no downstaging, again achieved the overall survival at 5 years of around 60%. And this is a rather large series from Zheng's group, China, no downstaging, HCC PVTT, 75 patients, but they could only get to approximately 40 to 45% at 5 years without downstaging. But they also have a series with downstaging. Now, what about radiotherapy and PVTT? I think the evidence is pretty much there, especially in the minds of the interventional radiologists and in their circles, that SPRT and other forms of radiotherapy can actually cause partial or complete remission. There's a large series of 120 patients that were published about a decade ago where 33% complete response and 49% partial response was seen in PVTT and IVC tumor thrombosis with SPRT. So 2 points are made. What about long-term survival in these patients who undergo this protocol? Asan Medical Center from Seoul, Korea published this paper where they had 17 patients with PVTT that were downstaged with TACE and radiotherapy and then transplanted, and they achieved a 3-year overall survival of around 60%. And then we published our largest to-date published series of patients with cirrhosis HCC PVTT who were downstage with radiotherapy followed by liver transplantation. So our protocol is that you assess these patients with a triphasic CT angio. They are all Child's A and Child's B patients. They should have a significant non-tumor volume of the liver. Their bilirubin should be less than 3. And they should not have any extrahepatic spread. But the tumor size and number is not a deterrent to taking up these patients for downstaging. We would generally tend and avoid extensive VP4. Like if there's SMB involvement, we'll probably not do them. And then if there are any lymph nodes on the scans, then you would go and do endoscopic ultrasound FNA of these nodes to rule out cancer. And once all this is done, then you plan a SPRT and TARE. That's the commonest downstaging protocol we use. And TARE 1, as you know, includes mapping of where you're going to put the yttrium-90, and you do that, and then you put the yttrium-90 in TARE 2, and then you follow it up with fiducial placement and stereotactic body radiation therapy. All this gets done over about 2 weeks. And after that, you wait 2 months. And then you do your first PET triphasic CT scan, and you keep on repeating the scans every 2 or 3 weeks for the next couple of months until you achieve downstaging, or you decide that you cannot achieve it. In that case, you can go again with SPRT or with immunotherapy. But if you achieve it, then you proceed with transplantation. And achieving a response means disappearance of FDG avidity and also arterial enhancement in the tumor thrombus. The thrombus may not clear, but the tumor clears. So this is what happens to these patients who have avidity, and then that disappears after the radiotherapy treatment. Another example of the main tumor, as well as the tumor thrombus in which the avidity disappears. So here are our results from this protocol, which were published, and this is updated results. So a total of 56 transplants have been done after downstaging HCC PVTT so far, out of a total of nearly 800 HCC patients, out of a total of nearly 4,500 liver transplants. And this data is of the 44 downstage patients who have more than 12 months follow-up. So overall survival 57% at 5 years and 61% recurrence-free survival at a mean follow-up of 49 months after downstaging and 46 months post-liver transplantation. And 18 of these are long-term survivors beyond 3 years, and 8 of them have actually crossed 5 years. So we found in our original cohort of 36 patients that patients who have a low pre-downstaging alpha-fetoprotein do better, and those with VP1 and VP2 do better than VP3 and 4. And those who have VP3 or 4, FDG avidity becomes a prognostic factor. Zheng, in his series where they did do downstaging before transplantation, also found AFP, tumor size, FDG avidity, and VP1 through 3 being as an absence of FDG avidity, low tumor size, and less AFP, and VP1 through 3 being good prognostic factors for response. So what about other modalities of downstaging? So we have now a small series of immunotherapy that we have given these patients and have taken them through transplantation. So this is our general protocol for HCC with cirrhosis, which Swapnil presented a little while ago in the morning. And now this is all of HCC. So it could basically go in 2 directions. You either go through surgery for patients who are resectable or transplantable upfront without the need for downstaging. That means they don't have extrahepatic disease, they don't have PVTT or IVCTT or HVTT, but they may have tumor any size, any number, right? And then there are others who will either have PVTT or extrahepatic disease or a combination thereof. So let's forget about the ones who have extrahepatic disease because they will have systemic therapy. So consider the patients who I have just mentioned in the previous few slides as being suitable for radiotherapy downstaging protocols. Now, what happens is that if they respond well, they go through transplantation. Sometimes they don't respond well, and we would put them on atezobev. We would also primarily put immunotherapy, give immunotherapy for patients who have extensive, diffuse, infiltrative local disease, very high tumor markers. So then we would actually preemptively go for radiotherapy, followed by immunotherapy 3 cycles at least, and then we assess them at the end of the immunotherapy, give a washout period for about 3 months, 2 to 3 months, but we try for 3 months, and then do the transplant. And this whole effect of radiotherapy and immunotherapy has now been documented by several people and published. So the so-called complementary effect of radiotherapy and immunotherapy happens basically because what happens is once you give radiotherapy to these patients, the tumor antigens are exposed, they are better presented, and there is T-cell activation. There is also upregulation of the inhibitory checkpoint molecules like PD-1, PD-L1, CTLA-4. So basically, this creates fertile ground for the immunotherapy to act better. So that's the logic of radioimmunotherapy. Nobody really knows whether you should follow immunotherapy after radiotherapy or give them simultaneously or give it before or after that, because basically there aren't large numbers, but the complementary effect has been documented. Anyway, so this is what happened to our patients who received immunotherapy along with radiotherapy. 5 of them were listed for transplant. We have transplanted 4. There was no operative mortality. 1 is still waiting for transplant. I think he's due for a transplant anytime soon. And the 4 that were transplanted did not have operative mortality. 1 of them died from sudden cardiac death, probably at about 5 months. He developed GVHD at 4 months, which incidentally responded to anti-TNF therapy, but finally we lost this patient. He had a sudden death, probably cardiac. So there is evidence of similar downstaging with other modalities from other centers, anecdotal reports. So there is reports of proton beam therapy followed by transplantation. There is other reports of just immunotherapy followed by transplant, which has been able to clear PVTT. There are also reports like ours of radiotherapy with immunotherapy, then followed by transplant. There was this meta-analysis for patients who underwent liver transplantation for HCC PVTT, and it was published in Journal of Hepatology earlier this year, and we made a comment on that. Nearly 700 patients, and the overall survival of the pooled patient cohort at 5 years was just under 50%, but those who were successfully downstage, their survival was 63% versus those who were not, whose survival was 41%. So there you have the survival figures with downstaging and transplantation. So keep that in one corner, but an important corner of your mind. Now let's look at what are the other options, and that's where transplant benefit comes in. So do these patients have a clear benefit from having transplant after downstaging compared to the other options which are available? So the other options are, as you know, would be locoregional therapy with TARE or with SBRT, or occasionally resection, occasionally TACE. Not a lot of them are suitable for TACE, or TKIs. Hardly anyone reaches long term. Most people don't last beyond 2 years. We know of all the TKI and immunotherapy trials, and with sorafenib, lenvatinib, you'll have 12, 13 months, and this is a mixed group of extrahepatic disease and PVTT. Then again, with CERT or TARE alone, you'll have 8 months. With atezo and bev, you might have 19 months compared to 13 months with sorafenib, and with durvalumab and tremelimumab, you may have 16 months instead of 13 months. So that's where you get to, and most of these are combined groups. These are not just PVTT. So what did we find? We found that patients who had the downstaging protocol and transplant had a 57% long-term survival, and the other therapies hardly lived beyond 12 to 18 months. So there was a clear transplant benefit at 3 years of 23 months and at 5 years of 33 months. And now, I think hesitatingly, but surely, INASL has now recommended that we should look at these patients, selected patients with the HCC PVTT, and try and transplant them after downstaging. So I want to focus your attention. You know the differences between the INASL modification of the BCLC and the BCLC 2022 staging. One of the main things is that we have separated groups into A1, A2, B1, B2, B3, and C1, C2, and so on. So I want you to focus on C1 and B3. Basically, B3 is diffuse infiltrative extensive local disease, and C1 is portal vein tumor invasion without extrahepatic spread. So while these traditionally go on to have systemic therapy, there is a cohort of patients who respond very well in terms of tumor markers and disease load and clearance of portal vein tumor, and they should actually be taken to transplantation. There are some others who will go to systemic therapy, immunotherapy, TKIs, and then they will move to transplantation. So that's why there's now a recommendation from the INASL consensus conference on HCC that's been recently published in JCAH, where, of course, HCC with major vascular invasion is an absolute contraindication for upfront liver transplantation, but selected patients with HCC and PVTT with segmental or sectoral HCC with no extrahepatic disease and a favorable tumor biology in terms of AFP and FDG PET may be considered for transplantation after downstaging, after an appropriate waiting period. So, to summarize, PVTT does not necessarily mean systemic spread, so you should look at it differently than treating metastatic disease. SIRT SBRT can result in partial or complete response of tumor in the portal vein. Selected patients with no extrahepatic spread should be downstage with TARE SBRT followed by living donor liver transplantation after 3 or 4 months with good outcomes. Downstaging means disappearance of FDG avidity and arterial enhancement. VP1 through 3, no FDG avidity, low pre-downstaging alpha fetoprotein, and smaller tumors do better. There is an emerging role of liver transplantation after downstaging by either radioimmunotherapy or immunotherapy alone, and there is a clear transplant benefit of this approach, downstaging plus LDLT, in eligible patients over alternative treatments like TKIs, immunotherapy, TARE, SBRT, or a combination thereof. Thank you.